Thank you. Thank you. Next.
Hi, Beth Malinowski, California Primary Care Association. Like the state, we're incredibly committed to supporting the successful implementation of the ACA. Right now, across our community clinics and health centers, actually 1 in 4 full certified enrollment counselors in the state are sitting. That's where they're doing the work and the incredible everyday work of actually getting folks enrolled in coverage and connected to care. Like Western Center and Law Property, we cannot separate the need for additional positions, which we support from the current application processing and IT system issues that are impacting the newly enrolling, and the potential for these issues to have a very significant spillover effect on the upcoming start of 2014 renewals for pre-ACA Medi-Cal enrollees. We're submitting and writing these concerns, and we've met with the department recently on this as well. We understand that some of these Medi-Cal processing renewal issues will get taken up in a later session, but we feel it's important to mention them in the context of these conversations here today. On the interim, we look forward to connecting with the committee staff on these issues, talking both about systems that are kind of challenges that are plaguing the application process right now, but as well as kind of what the impact is for our 2014 renewal process, and what this could mean for pre-ACA Medi-Cal enrollees that may get caught in all of these problems. So again, look forward to continuing the conversation. Thank you.
So ICM, Health Access, we want to echo the comments of Western Center on Law and Poverty and say that we too are troubled to hear that close to 670,000 Medi-Cal applications have not been processed. We are pleased to hear that the department will allow for self-attestation of residency and income verification. And we look forward to working with the department and the committee to address this issue. Thank you.
Thank you. So just to follow up on the backlog, help me understand what that means for somebody who's seeking to be enrolled. Is there any provision where they can access health care pending the determination, or are they just on a holding pattern until the verification is complete?
So in terms of provisions, when someone applies, once they're made eligible, their effective date will go back to the date of application. For kids, there is a presumptive eligibility process, so they can get on right away while it's pending. For adults, if there is an urgent need, and we'll talk a little later about our presumptive eligibility through the hospital, that they could get on for those. But those just applying through Covered California, what we're trying to do is to work to clear this backlog as quickly as possible. And as those who testified noted, we recently announced there is a big population that just are missing their residency verification. So we are going to take that requirement to provide paper documentation, and we hope that will help clear the backlog so our counties can focus on the remaining cases and reach out and get income information. It's primarily income information, some cases citizenship information, to do as quickly as possible. This backlog is not what any of us want, and we want to work to clear it. It is related to everything from the enormous response and interest in coverage to technical difficulties with the systems that we have, and we're trying to work through it as quickly as possible. And for those who need immediate coverage, there's also the ability for them to go to a county human services office. We've provided guidance on immediate need in terms of if there's an urgent need that the counties can override and get them onto coverage.
So it sounds like the self-attestation addresses close to half of the backlog.
That's what our data shows, yeah.
And then what's your best estimate as to clearing?
I don't want to be we're trying to do it as quickly as possible. I'm hoping in the next several months, but it also depends on what happens in March, the remainder of March. We expect a lot of applications to come in because Covered California is doing a lot of outreach with the end of open enrollment. So there's many different factors that play into that.
And are the eligibility workers able to provide somebody who's in limbo with referrals if they need emergency medical care?
Yeah, so again, we provided guidance, our counties, to the extent someone comes in and they have a very sick child or are pregnant or have chronic illness, that the county can immediately get them onto coverage in this limbo period. the same as they could refer them through, as I said, for kids to get onto immediate presumptive eligibility or through the hospitals. So they provided this information so that we can try to deal with immediate needs.
Thank you, and you'll keep us
Absolutely.
informed as to how the backlog is being cleared?
Yes.
Thank you. Any other questions? Seeing none, we're going to hold that item open and move on to what's this? Item 6. Item 6, medical eligibility under the ACA, the hospital presumptive eligibility.
I think it's a good topic to come right after this. It is one of the places where people can get on coverage immediately. So just to give just sort of a general update on the program itself, as noted, the PE program was instituted through SB 1X1 last year as, again, part of the overall ACA implementation. Through this program, hospitals can apply to provide presumptive eligibility to individuals who come into their facilities. Individuals would then be required to provide some basic information. It's a one-page application. It's really about household and income to determine if they would be likely eligible for Medi-Cal. The hospital then would enter this information electronically and receive an immediate PE determination and be able to provide a paper benefits card to the individual. For those who are found eligible through this process, they would be provided full scope benefits for up to 60 days. And if they do submit a full application, the PE period would continue until that application eligibility is determined. So just a couple of updates on the numbers. We had provide the staff with numbers, but we have new numbers, so wanted to update you on all of that. So far, we have had through March 15th, just over 20,000 people who have been approved through the hospital PE program. So I think that's an increase of about 9,000 from just a couple of weeks ago. And then in terms of hospitals who are participating, we have approved 138 hospitals for participation in the hospital PE program, and we're seeing just under about 100 who are currently actually actively processing PE applications. We're continuing to work with the hospital associations to make sure that they have the necessary information to get their provider agreements in and approved, and working through those quickly. So that's just the general update. Obviously, this particular item was related to the BCP request. This is not a request for positions. It's simply a request for funding. And this is really funding that will be used to hire IT consultants to assist us in enhancing the business functionalities and reporting capabilities in our med system required for this program. We got the program up and running as quickly as possible and utilized existing IT resources, but we need these resources to really make sure that we will be able to do appropriate program oversight, monitoring, and performance standards measurement, integrity, and compliance with ACA rules. And so that is why we have this request before you.
Great, thank you. LAO, anything on this? Department of Finance? Public comment, please come forward.
So I assume Health Access, we are in support of presumptive eligibility. Thank you.
All right. Are there any other comments?
No, but I'll make a motion on this item.
Yes, this is an item up for vote. We have a motion. Any concerns or objections? You guys okay?
Why don't you announce it, choose, or do you want to hold it over?
Well, let's put it over for a moment.
Okay.
We can come back and vote on that. We'll wait
Great.
for our other member to come back. I'm fine with that. All right. The next item. Oh, okay.
Sorry.
On item number 6, Medi-Cal eligibility under the ACA. This is an item open for a vote today. There was a motion by Senator Monning, and are you? You're a no? Okay, so that will be recorded as 2 in support and 1 in opposition. Thank you very much. All right, item 7.
So the next item is our what's called the Bridge program. In order to ensure as individuals on the Medi-Cal program move up in eligibility income levels and get onto advanced premium tax credits, we wanted to ensure that there's continuity of care as well as ways to make it as affordable as possible. So we've been working with Covered California on what we call a Bridge program to transition them in a way that provides that comprehensive coverage, remaining with the same plan provider at an affordable cost. It's taking a lot longer to implement, get federal approval. And so we're here today to ask that we withdraw this BCP for now. We will. I know there are questions about the resources too. We'll continue to look at that next time when this comes up. But for now, we think it's premature at this point, based on where we are with Covered California and our federal partners.
Okay, thank you very much. I'll entertain a motion to reject the proposal.
So moved.
All right, we have a motion to reject the proposal on item number 7. Everybody okay with that? Okay, all right, then we will reject that proposal. Thank you very much. We'll go on to the next item. Item number 8, ACA estimated savings due to claiming enhanced federal funds. And the LAA will be presenting this item. You get a little bit of a break, Mr. Douglas.
So under some of the new ACA eligibility rules and the optional expansion, the state may be able to claim an enhanced 100% federal match for some enrollees who would have previously qualified for a 50% match instead. So as part of last year's budget package, AB 82 requires DHCS to report to the legislature each January and May the projected general fund savings attributable to claiming enhanced federal funding for previously eligible populations. The law also requires DHCS to confer with applicable fiscal and policy staff no later than October 1st, 2013, regarding the potential content and attributes of the information. This information was not included in the governor's January budget, and the administration indicates that it was unable to provide this figure because it did not have data to base its assumptions and hopes to have this information available at the May revision. In our view, preliminary fiscal estimates of factors that will likely have or potentially have significant fiscal effects on the amount of general fund spending in the program should be included in the budget, even if those estimates are highly uncertain and subject to change. The Medi-Cal budget frequently contains preliminary estimates and assumptions that are based on limited data and experience. Such estimates serve as placeholder until more refined estimates can be completed and allow for more informed budget deliberations. We recommend that the administration report at budget hearings on the reasons it failed to confer with all of the relevant legislative staff on this issue. In addition, we recommend the legislature direct the administration to describe the previously eligible populations that may fall into this category of being able to receive an enhanced match instead of the 50% match, the total amount of general fund that was spent on these populations in prior years, the major sources of uncertainty that led to the decision to not include this estimate in the January budget, and the administration's timelines for providing its fiscal estimate to the legislature.
All right, thank you very much. And Mr. Douglas, would you like to respond to those comments?
I thought I got a pass on this.
Just momentarily.
Oh, darn. Well, as the LAO said, there definitely is potential for savings. We have Medi-Cal-only disabled populations, given the streamlined eligibility, that may not go through the disability process, and that will happen over time. This is a big change, and we don't know how quickly those types of changes, behavior change, will occur. Similarly, on share of cost, there's Medi-Cal share of cost, where individuals right now are getting on with what we call the share of costs and spending down. They could now come on as newly eligible. Again, we don't know how all this will change, and this has created the uncertainty, same with parents and whether their income change. And it really gets to, with that uncertainty, at the same time we're seeing large increases in enrollment. We did not think it was responsible to put in estimates that, we need to stay within our appropriation, and we just wanted to hold off until we have good estimates. I don't even at this point commit we're going to have it in the May revision. We know we need to do this, and we want to track it, and there are these potentials, but it's a matter of timing and making sure that we have accurate information, even if it is still estimates. At this point, we don't have any information to really create those estimates.
Do you have a comment?
I think we would just like to work with the administration as much as possible to try and get an understanding for how they've looked at this issue so far and what sort of information they're looking at and the major sources of uncertainty. So we hope to continue a conversation with them.
Yes, I think we all understand that there are definite uncertainties, but it will be helpful to have as much information as possible by the May revise so we can, of course, make our informed decisions. So we hope we can at least get some information together by then. That would be very helpful. All right. Okay, any Department of Finance, any comments? Public comments? Members? All right, this is an item that will be held open, and we look forward to continue working with you on it. Next item, statewide outpatient Medi-Cal contract drug list.
Sure. So first, to provide an overview of the proposal, it has two components. First, it establishes the Medi-Cal contract drug list, what I'll call CDL, as the Medi-Cal core drug benefit across all Medi-Cal delivery systems, both managed care and fee-for-service. Managed care plan drug formularies would be required to provide access to the same core drug benefit without prior authorization and subject to the utilization controls that would be established by DHCS. Any drug not listed on the CDL would be subject to prior authorization. The CDL is a list of outpatient drugs covered by the Medi-Cal fee-for-service pharmacy program, and there are specific conditions specified in the CDL, and they're subject to specific documentation requirements like age restrictions, diagnosis, quantity limits, and et cetera, and there are contract terms that are negotiated with drug manufacturers. The second component of the proposal, it would be to authorize DHCS to negotiate and collect state supplemental drug rebates for all drug utilization and Medi-Cal programs, including those from managed care organizations. This proposal would align the collection of state rebates across all Medi-Cal programs. Federal law permits the collection of federal drug rebates from managed care organizations, as well as state supplemental drug rebates for all state drug utilization, where CMS has approved the rebate program and there are contract agreements in place. However, currently state statute prohibits the collection of state supplemental rebates from managed care organizations. However, there is no prohibition to collect those rebates on fee-for-service or for COES drug utilization. I did want to make two clarifying points on page 45 of the agenda that I had let the committee staff know about earlier this morning. The chart that's on page 45 indicates that supplemental rebates are not currently collected for those carved out drugs from managed care, and that is inaccurate. We provided that information inaccurately to the committee staff. Secondly, they are collected. So then secondly, under the chart, there's a statement about the potential to collect rebates on $2 billion worth of drug spend. So that number would actually be $1.3 billion because the carved out drugs are currently being collected on, but did want to clarify that, that we would only be able to collect rebates on the portion of the drug spend that is not for generic drugs. There are no supplemental rebates for generic drugs. So that, just wanted to have those two clarifying pieces.
And I just announce for the record, an errata agenda has been posted to the budget website with those corrections.
Thank you.
Thank you.
So then we were asked to provide highlights of the issues and concerns raised during this week's stakeholder meetings. We did hold two stakeholder meetings this week, one with representatives from the pharmacy provider community and the second with representatives from the pharmaceutical industry. We are going to have similar stakeholder meetings, one with our Medi-Cal managed care plans and another with beneficiary advocates, but those have not happened yet. So the issues and concerns I'm going to highlight here were just from the two that were held this week. So a couple of the major ones raised was concern about whether the proposal would result in a single statewide formulary with no flexibility for plans to add other drugs. That is not the case. Plans would be able to add additional drugs beyond the core benefit. The core benefit would just require that they provide the core benefit drugs without prior authorization and the utilization controls that we determine.
So I'm sorry, could you go back?
Sure.
You're stating that why don't you just restate?
Sure, I can restate it. So there was a concern that this would limit the drugs that plans could have on their formulary, and that is not the case.
Okay.
They can add additional drugs beyond the core benefit that we would be having as the statewide. The second was a concern about plans being able to enact their own prior authorization and utilization controls. Plans, again, outside of that core drug benefit would be able to have prior authorization and utilization controls, but they would not be able to have those for the core drug benefit that we would be establishing. There was questions about whether there would be a process in place for public and plan input on the creation of the core drug benefit. I will describe a little bit later what that public process is, so there certainly will be a public process for that. And there were concerns about ensuring continuity of care from fee-for-service to managed care or from plan to plan under this proposal, and we actually think this enhances continuity of care beyond what the current continuity of care requirements are, and I'll get into that since you specifically wanted me to address continuity of care later on. And then one final concern that had been raised was whether this would have an impact to existing contracts between drug manufacturers and both the plans and the state. We think that's likely minimal, since existing contracts can run their course or can be amended and canceled. And obviously, we're still a ways from actually implementing this. We want to have this whole stakeholder process to develop the core drug benefit.
I'm sorry, could you go back on that
Sure.
one too?
Sure. So there was concerns about the impact to existing contracts.
To
sorry?
manufacturers.
Between drug manufacturers and the plans, or drug manufacturers and the state. And we don't think that there's a significant risk of that.
Because, you stated because?
Because the existing contracts can run their course, or we can also look at amending or canceling contracts depending on how that would work.
Okay, thank you.
So in terms of a timeline for the proposal and working with stakeholders, there's a few things I want to mention. First, we will be establishing a governance steering committee to manage the transition of planned drug formularies to include the Medi-Cal core drug benefit under this proposal. Assuming this proposal is approved, we anticipate having that committee established by the fourth quarter of 2014. The steering committee would consist of members from plans, the Drug Use Review Board, the Medi-Cal Contract Drug Advisory Committee, and potentially others. And they would be developing the guiding principles and manage the transition of planned drug formularies to include the Medi-Cal core drug benefit. Once this proposal would be enacted, we would also begin discussions with plans individually and with the plan associations to talk about this transition. The second component of the stakeholder process is that the proposal requires DHCS to consult with the Drug Use Review Board and the Medi-Cal Contract Drug Advisory Committees. We expect the composition and function of these existing committees will reflect representation from entities associated with the plans, as well as folks involved in fee-for-service. The DUR board, the discussions on the core drug benefit, any votes and resulting recommendations to DHCS would be conducted openly in public in accordance with requirements set forth in the Bagley-Keene Open Meeting Act. These meetings would continue to be noticed to the public, including publishing agendas and providing opportunities for the public to speak at the meetings. And we will also just continue to meet with individual stakeholders as needed outside of these other meetings to discuss general issues and concerns related to this core drug benefit. So then there was also a question regarding the existing continuity of care protections related to prescriptions and medications. Currently, the continuity of care provisions are in the Welfare Institution Code 14185B. Under those continuity of care provisions, what that lays out is that a Medi-Cal beneficiary who is enrolling into a plan, whether from fee-for-service or from one plan to another, if they're switching a plan, that they would be able to continue use of a single source drug, which is part of a prescribed therapy that's in effect prior to their enrollment into that plan, whether or not that drug is covered by that new plan's drug formulary, and they would continue to be able to access that drug until the prescribed therapy is no longer prescribed by the contracting physician. So this existing continuity of care statute would not be changed, but we actually believe it's limiting in nature, and from a practical perspective can result in beneficiaries being switched from drugs under plan-specific formularies. The reason for that is that the current statutory requirement does not address generic drugs. So all a plan has to do is actually just provide a drug that's in the same therapeutic class, but it's not the exact same drug. With our core benefit design, whatever core benefits we put on our contract drug list, the plan would be required to provide that exact drug without prior authorization. So then the next issue was regarding the FPACT drug formulary and some questions you had about that. The Medi-Cal contract drug list has a broad list of drugs in different therapeutic categories, including prescription and over-the-counter drugs. The FPACT formulary generally lists drugs related to family planning. This proposal would establish a core drug benefit, including family planning drugs that would be required to be covered on the FPACT formulary. Existing drugs and new drugs on the FPACT formulary that are not included in the core drug benefit would continue to be on the FPACT formulary to the extent they're medically necessary, and or if there are drugs subsequently added to the core drug benefit by DHCS through this normal drug contracting process, those would also end up on the FPACT formulary. And then finally, there was a request to comment on the potential need to adjust Medi-Cal managed care rates as a result of this proposal. That is something we are continuing to look at. At the end of the day, it will really depend on what is on the core drug benefit and how that aligns with what currently our plans have in their drug formularies. we would be looking at what the potential changes would be in utilization and cost. And if a rate adjustment is necessary, we would certainly make that. It really will depend, like I said, to the extent that plan formularies are adhered by plan physicians today. So if they are, if the addition of CDL drugs as a core benefit doesn't actually adjust the utilization, it would actually not require an adjustment in capitation rates, but it's something we'll have to continue to monitor and look at.
All right, thank you very much. Any questions, comments, members? All right, legislative analyst.
Thank you, Madam Chair, members of the committee. Felix Su with the LAO. First of all, we are still looking in detail at this proposal, and we will get back to the legislature hopefully by the time of the May revision with our formal recommendations and findings. In the meantime, we do have some initial remarks and potential concerns. First, we agree with the staff recommendation to hold this item open. The proposal before you today covers a very complex set of issues and has implications for the overall fiscal and policy direction of the Medi-Cal prescription drug benefit. Now, the staff agenda provides some very useful background information and an overview of these complex issues and points out that there are potentially some very important trade-offs for the legislature to consider within this proposal. So for the purposes of today's hearing, we would like to try to break down these trade-offs in the simplest terms possible so that everybody's on the same page in understanding what the proposal entails. First, in terms of fiscal trade-offs, as the agenda points out, the bulk of drug dispensing in the Medi-Cal program today occurs in the managed care system, particularly after the transition of seniors and persons with disabilities to managed care. Now, presumably, the fiscal rationale behind this proposal is to create a statewide CDL that allows the state to potentially negotiate greater manufacturer rebates, and by doing so, to require plans to dispense a greater volume of these drugs that are covered by the rebates. Now, what we feel the administration has not adequately addressed or acknowledged in presenting this proposal is that the rebate-covered drugs are primarily brand-name pharmaceuticals. So in essence, this proposal would compel plans to dispense comparatively more brand-name products than their generic equivalents. Now, while the state could potentially net greater rebate revenue, at least in the short run, from pursuing the strategy, it seems likely to us that in many cases, the brand-name drugs will still be more expensive for the managed care plans to procure through their pharmacy benefit managers or PBMs and to dispense through their network pharmacists. Now, in turn, this logically would lead potentially to upward pressure on general fund expenditures due to the potential requirement for DHCS to pay higher capitation rates that reflect the higher unit costs to plans of dispensing more brand-name drugs. Second, the potential policy trade-offs. The department claims that a single statewide CDL would create a more uniform drug benefit for both prescribers and for patients across different health plans. Yet, to achieve this potential uniformity, the proposal would necessarily take away some element of local control and flexibility from managed care plans. That is, their ability to develop their own internal formularies through the recommendations of their own pharmaceutical and therapeutic committees, and to manage prescription drugs as an overall benefit in terms of the strategy to coordinate care and to lower costs overall. Now, one could argue that it is precisely this local control and flexibility that is a key tenet of managed care in the first place. Now, finally, notwithstanding any potential merits to this proposal, in our view, the trade bill language today in its current form is somewhat vague and light on details. We really want to reiterate that this is a very complex and significant change that the department is proposing, and the legislature may consider studying the issue in greater detail through the policy process rather than trying to rush a decision through the budget. Thank you.
Thank you very much. Department of Finance. Any comments, members? Public comments, please.
So I assume, on behalf of Health Access, we want to just state that, in our perspective, the administration's proposal is very confusing. The point of Medi-Cal managed care was to get the purchasing power of the plans. It's unclear whether the administration failed to account for the reduction in drug rebates when estimating savings from managed care. Additionally, the health plan's proposal also doesn't make much sense given how DHCS negotiates, which is manufacturer by manufacturer rather than by class of drugs. We're pleased to know that this item will be held open, and we look forward to following this issue.
Thank you very much.
Jennifer Kent, Local Health Plans of California. The plans are opposed to this proposal. We have conveyed this through written correspondence with the department, and we've participated in several meetings with them regarding this proposal through either the CEOs or the chief medical officers. Our concerns are twofold. The formularies that most of the plans have are somewhere between 80 and 90% generic pharmaceutical utilization. When we took the SPDs into Medi-Cal managed care, we transitioned them off of brand name drugs and put them onto generics. And I think that what we are also struck by is that there seems to be an absence of problem. When you look at the Medi-Cal managed care dashboard for the last quarter, and they list out the grievances and appeals that have gone to the state for purposes of what beneficiaries have raised, there was 139 pharmacy grievances. So if you have a program that's serving approximately 9 million individuals, and there were 139 grievances across the state in pharmacy, you have to question whether this is really a problem or not in terms of continuity of care. Plans, if you move from a plan to a plan, because there are heavy generic formularies involved, you're moving generic to generic. And so if you put this in, we would be transitioning people back off of generics potentially and putting them back on brand. And so we question whether that's a good policy reason or not. The fiscal ramifications, obviously, our ability to negotiate and purchase drugs, especially for the local health plans of California, is not, the leverage is just not there the way that the state can negotiate these prices and rebates. We don't get the rebates, and we can't get the prices that the state gets. And so what we have done is we have used a variety of factors to make our pharmacy benefit as efficient as possible. The department further has an efficiency factor in our rates that if we do not hit certain cost factors in our capitation rates around pharmacy, there's a pharmacy efficiency factor that gets employed, which is basically a cut to the overall rate. We asked the department, are you going to change the efficiency factor if you're going to require us to use your statewide formulary? And they said no. So it's just one more reason why we are opposed. The state has given us the risk. They've given us the population. They are paying us a rate to manage this population. And then to therefore then come and say, we want this formulary to now be back in your hands as the state, and we will tell you what you can and can't buy, and whether you can use prior authorization or utilization controls on certain drugs, is going the opposite way of what we just transitioned. So with that, we're opposed.
Thank you.